I am Dr. Pragati. I am second year DNB resident at PSIC Noida. So Dr. Nitika Singh, third year PG resident, ESI Basavara.
So this is after a lull of about 3 years, which I had been holding these programs in UCMS. But maybe because of Corona and maybe because of my superannuation, I shifted to another place. But then I must say that as I came on the first day, I still remember the most important word is the synergism. So my head of the department has been very cooperative, Professor Kaushal. So we thought of doing it. Last time also I did, but that was not on the clinical cases. So the beauty of this course is basically the live cases which will be discussed with the experts. So I welcome Professor Pankaj Garg, who is from senior at Sarganga Hospital, with tremendous experience in neonatology. So, and then Dr. Kaushal, who is heading the department here. I welcome you here. We will be sticking to times. It will be an interactive session. You can note down the questions or whatever way the experts want. And the cases will be presented. Two examinees will be there. One examinee will do the history taking, the other will do the examination. I hand over the mic to Dr. Pankaj.
Thank you, Dr. Gomar. Thank you, Dr. Kaushal, for giving me this opportunity. I think interaction makes it interesting, and cases you do present on the rounds. So I always tell my fellows, we have been doing DNB Neonatology fellowship since 2005, and I have been teaching DNB pediatric students since 1998. So it's very important that you should not be thinking something different once you are presenting a case in exam. You should think as you are presenting in the rounds on day-to-day basis. That kills your anxiety and that improves your performance. So just think that you have to solve this query. Don't think that you have to crack the exam. If your main focus is to solve the patient, solve the query, take care of that newborn, that exam is just one step into that direction. Just relax, enjoy this journey. As when you board any aircraft, the pilot says that, okay, now time has come to fly. Just sit back and relax. So that is the word I like to say. And then once this presentation starts, people present, ask questions. I always tell that there is no silly question in this world. All questions are important. It's only that if you are able to generate questions, you will always get answers. Answer is very, very simple thing to follow. Question is more. So do that. Okay, we can start. Thank you.
Sure, I fully agree with Dr. Pankaj. Today also I would say don't hesitate in asking any question. Whatever comes into mind, the person next to you must be knowing about it. But if you have any query about that, just raise it. It's always better. That makes you a habit of putting questions also. Pankaj said कि question raise करना मुश्किल है, answer तो मिलते हैं. अभी नहीं मिलेगा, हो सकता है I am not able to answer this today, but I definitely go and find out the answer for you and we'll get back. So let's start without wasting any time. I again welcome you for this, and I think you have taken a very good step. So you must be giving an exam, so you get lot of information, lot of confidence today. I'm pretty sure. Thank you. Dr. Vaishnavi, she is from our institute, Dr. Kaushal, with Medical College Hospital, and she is second year DNB. She will be presenting the history part of this case. Because it's a small neonate, we just bring the neonate as the things progress. So let's say sitting in a little thermometer environment. Thank you.
So, good morning everyone. I am presenting a case of a 1 month 8 days old female child, termed by gestation, birth weight being 3 kg, born with para 3, abortion 1, death with live 1, mother, third by birth order via non-consanguineous marriage, belonging to Hindu region, residence of Nangolai, Amarkolli, Delhi. Baby was brought by the condition being 22nd of August 2024 with chief complaints of fever for 3 days. Informed me in the special fever for 3 days, fast breathing for 1 day, and cycling movement of upper and lower limbs at the time of admission. At the time of presentation to emergency. Baby was apparently alright in 14 days of life when she developed fever, which was insidious in onset, low grade, undocumented, not associated with any rashes.
So in casualty, you get a baby who days 14 with fever.
17 days of life
19 days of baby with fever.
with fever and fast breathing.
So fever and fast breathing means which bacteria? Yes.
Respiratory system.
Infective respiratory.
Yes. When baby was received at emergency, baby had cycling movement of body, of upper limb and lower limb, multiple episodes associated with irritability, and associated with uploading of fibroids or falling from mouth, and doctor informed the mother that it was serious. There was no history of letharginess or refusal of feeds or high pitch track. There was no history of suppressed sex cycle or forehead sweating during feeding or bluish discoloration of lips or peripheries. There was no history of top feeding or bottle feeding. There was no history of loose stools, vomiting or crying during intubation. There was no history of any previous hospitalization and no history of any bluish discoloration of body.
Now I want to
Can you summarize the thing, whatever you said? I think there was a problem on that side. Just give half a minute. Just whatever you have.
So 1 month 8-year-old term may be appropriate for gestation weight with birth weight of 3 kg. Presented was on 17th day of life with fever for 3 days and fast breathing for 1 day. And at admission, the baby had cyclical movement of upper limb and lower limbs. So this is the mother was a para 3, live 1, abortion 1, death 1. With mother's age is 25 years and father's age is 27 years. The couple was married since 6 years. There was this first parity was 5 years ago. A male child born via LSCS. The baby expired on day 3 of life. Queried due to meconium aspiration as per the mother. The baby had distress and baby passed meconium in the uterus and baby had aspirated that. Then after a year, the mother had a spontaneous abortion at the 5.5 months of age. There was mother doesn't know anything about that. And this is the current pregnancy is a so I would like to start with the first trimester. It was a spontaneous conception and pregnancy was detected by a positive UTT done at 6 weeks of gestation. LNP was 1st of November 2023. There was no antenatal USG done in the first trimester. There was no history of fever or rash during the first trimester. No history of any drug intake or no history of any irritations. Second trimester, first ultrasound was done at 3.5 months of age. Mother was immunized twice during the pregnancy with interval of 1 month. Quinine was fed at 5th month of gestation. Mother had not taken any iron or folic acid tablet during the second trimester. No history of any blood transfusion in mother. No history suggesting of any hypertension or gestational diabetes. So third trimester, third ultrasound was done and was shown to be normal. Mother did not take any iron folic acid during this period also. There was a history of maculopapular rash all over the body associated with itching 7 days prior to delivery. Was not affected with any fever. Mother applied some medication and after that rash resolved according to mother. The onset of labor was spontaneous. Mother started having abdominal pain at the morning on the day of delivery and was admitted to a private hospital. There was no rupture of membranes. Mother was taken for LSS in view of previous LSS. Baby cried immediately after birth with a birth weight of 3 kg. Baby was started on formula feeds during the first 24 hours as mother was not able to feed the child. And later, after 24 hours, baby started on exclusively breastfed and the exclusively breastfed continued till the 17 till the 15 days of life. After that, baby passed schools 8 to 10 times a day and urine for 6 to 8 times a day. And baby was receiving birth vaccines.
So from birth till day 70, they were examined or they were seen by somebody in these 70 days?
The baby was discharged further.
From the hospital and never came back. What do you think was the cause of this maculopapular rash which mother had 7 days before?
Sir, might be some virus.
How did you ask that history? How did mother describe maculopapular rash?
She was like, no, जैसे आ रहा था पूरी body पे.
मोदी जैसे पूरी body.
The onset she doesn't know from when it started. She said all her body was present. She applied for some itching was present. She applied something on it and it resolved after 2 to 3 days on its own. She did not show it.
What could be the possibilities?
So third trimester might be intrahepatic polycystic pregnancy can associated with itching. The rash is associated with itching, so might be.
Which was not investigated for that.
Yes.
Does the rash resolve in ISCP? Does the rash resolve by applying injection? Then ISCP is not a possibility. ISCP rash actually has a advancing which increases. And what are the drugs which they use for ISCP, which may reduce rash? Was used in this patient?
No, sir.
So ISCP is not a strong process. What else?
Viral infections.
Viral infections. Usually, which viral infection rash comes on first day without fever?
Yes.
You can also participate.
Yes. Varicella, the rash is not maculopapular. What type of rash is there in varicella? Vesicle. Or pleomorphic rash. Right. What is pleomorphic rash? Means so she's saying maculopapular. So that is also less common. What else? Drug
induced.
But she is not taking any drugs. Absolutely. So something which comes and goes is not infective rash. It is most likely allergic rash.
Something triggered and then might have taken separately one drug, anti-histaminic or so.
Even if you don't take any drug, it disappears, and then it appears somewhere else. So articular rash, allergic dermatitis, they are even said that they go disappear, no fever, resolved on its own. So though it may have taken production in your examination later on, but at this phase of it, doesn't look like something specific. It looks like more of an allergic rash. Right.
So learning here is if you have uttered a word, you should have tangent answers for that. If you said maculopapular rash, then you should have couple of causes and what it exactly was. You may not be 100% correct, but you should have some explanation for that.
The road is very conventional to say it's spontaneous conception. I always object to that word. How can you conceive spontaneously? Natural conception. See,
Wrong is natural.
yeah, I know this word is commonly used by all, in that I was pointed out very specifically. But you are trying to say it's not an assisted reproduction. It is not an IVF, it's not an IUI, something like that. I understand that. But it is nothing like a spontaneous conception. Natural, that's a better word. Fair. Your history from antenatal period is complete. Right. So at delivery, you said you told that it was LSCS. Did you require resuscitation? No. You were discharged in 3 days. Okay. We'll come back to your details now.
So post-mortem to the hospital stay. The seizures were managed at emergency and but seizures were persistent, but post-injection calcium, no fresh episode of seizures were noted. Baby was admitted, started on O2 support, and started on some IV medication for first 4 to 5 days. Fever was documented during the hospital stay as 100 to 101 degree Fahrenheit. Resolved after 6 days of antibiotics.
So in a newborn who develops fever, what are the possibilities in that? Newborn with fever on day 18 of it. So whenever you have some possibility in your mind, then your history, your examination flows in that direction. What are the causes of fever in a newborn? Okay.
Infections.
Infection, which infections?
So, bacterial infections.
So we had fever, we had also seizures, also had fasting, right? So what infection comes at top of your mind? So will UTI be at the top of your mind? UTI will be at top or meningitis will be at top?
Meningitis.
You say that. So meningitis is at the top of your mind, right? What else? So fever is one category. In that we are saying meningitis is one. What else? We also have fast breathing. Maybe you got pneumonia, you have hypoxic seizures, right? So pneumonia is another possibility. What else? So all these are in the category of bacterial infections, bacterial fungal infections. What else? Any other differential in your mind for fever? Dehydration. Right? Dehydration. What is dehydration fever? Yes, ma'am. What is dehydration fever?
So because of decreased oral intake, decreased feeding, the baby is being kept in a warm environment.
So why, if an adult gets dehydration, a pediatric patient gets dehydration, they don't get fever, a newborn gets fever?
Because adaptive mechanisms are not that much developed in the newborn. The skin is thin.
So they lose more weight, dehydration, they do less sweating, so that is why they don't reduce their temperature. And most important, they cannot control their own environment. So adult, if he gets dehydrated, he will remove the clothes, he will take care of the environment, ambient temperature. Pediatric treatment will also do that. Newborns are not. So newborn's environmental temperature decided by you. You are giving the baby warm, you have been told to give the baby warm, and baby is dehydrated. So you cannot take care of your ambient temperature, you can't sweat, they get dehydration. So non-infective causes dehydration. What else? Any other cause of fever in newborns?
Yes, we could read the elements, but there are so many concerns.
Otherwise, if you sleep off. So only infection and dehydration fever are the differentials, then how will you progress with other things? Important. Yes, you have to say something. Infection is one, bacterial sepsis, meningitis, septicemia, pneumonia,
Inborn error of metabolism.
which inborn error metabolism leads to fever?
Thyroid
Tyrosinemia will lead to liver dysfunction, lead to coagulopathy. Galactosemia indirectly can. Galactosemia can dispose to E. coli sepsis and then fever. So it is again a sepsis underlying cause can be galactosemia. What else? Can it be malaria?
Yes.
Can it be dengue? We are in the dengue season right now. Lots of them get fever. Can it be COVID? We saw a lot of COVID patients at that time who had gone to mothers with COVID and they had fever. So don't restrict yourself to only bacterial fever.
Once you say infection, cover the whole spectrum, bacterial, viral, protozoal, fungal. At least differential should come into your mind.
But can be endocrine cause of fever in that people. Hormonal causes. Can it be thyrotoxicosis? Mother is on some drugs. Baby is hyperthyroid. Baby has lost weight also. Baby is fast bleeding also. Baby has fever also. All these things can be the thyrotoxicosis. Fetal thyrotoxicosis. Right? So just broaden your mind. Just only restrict. I've seen this very commonly that because most of them will turn out to be infections. You don't think about others. Think about all. Right? Now fast breathing, cyclic movements and fever just pushes you to a pathology. But fever per se should be a broad mind. Right? Okay, go ahead.
Gradually oxygen was tapered and feeds were initiated. Baby was off to support on the 7th of admission. Baby was shifted to full phase. On day of admission 8, baby started having mucopurulent discharge from the left ear, slightly yellowish in color and false smelling. Baby was noted to have a weight loss during hospitalization.
Weight loss. So birth weight was 3
Birth
kg.
weight was 3 kg.
What was the weight at admission?
At admission was 2.8 kg.
2.8. So is it normal?
And now, today how much?
Today is 2.5 kg.
2.2 kg. So what do you think is the cause of this weight from 3 kg at birth and 2.8 kg at day 18? Is it normal or not normal?
No sir.
What would have you expected?
Baby has not crossed
What would you have expected weight at day 18? A normal down 3 kg born,
till 10th day of life. The baby regains the weight
right?
at the child. And after that 10 to 20
And to 20 fetus.
30.
So 30 into 8, 240 plus 3, 3.24. Right? And is 2.8. So what is the deficit? 440 grams. 440 grams deficit means how much deficit from birth? A lot of girls are close to 50%. He has lost. Right. So what could be the cause? If he was an exclusive breastfeeding and you said that baby was passing urine also, was passing stools also, what could be the cause of weight loss in first 80 days?
so feeds would be not and the mother would be not good to the child. Dehydration can be.
Baby was passing urine 6 to 8 times that he would have done. In spite of, I would say, adequacy of the baby's using weight.
So you have to differentiate if it is lactation failure or it is something abnormal with the baby. When she is a mother who did not have experience of a child bleeding before. Her first baby died at 3 days. But she is exclusive breastfeeding and baby is passing 6 to 8 times time. The baby was not weighed any time between. So it can be lactation failure, but at the back of your mind is what Dr. Kaushal is saying, passing 6 to 8 times urine means that maybe she was feeding all right. So if she is feeding all right, baby is still not gaining weight, what is in your mind? Malabsorption with type, lactose intolerance. So what is it a primary or secondary lactose intolerance? There's no infection as yet. So primary lactose intolerance is extremely rare. Okay, just an MCQ question for you. Tell me one country where primary lactose intolerance, out of all the cases in the world, majority, more than 50% cases reported from one country of primary lactose intolerance. Otherwise, whatever, I have not seen in 30 years of my life of experience of neonatology, any primary lactose intolerance, all are secondary. Only one country has, and that is because of inbreeding, genes, genetic issue. Anybody? Finland. Finland is the only country, if you are practicing in Finland or patient comes from Finland, only then you think about primary lactose intolerance. Otherwise, it's very extremely rare. Right. So, lactose intolerance does not bring bells into my ears. What else? So, what I will think is that patient is having something going on, some pathology, some metabolic stress is going on, some infectious pathology is going on right at birth, right from birth, which is not allowing the baby to grow right. Maybe some inborn error, maybe some infection will be acquired in the mother's womb and now is manifesting. Something is going on which is not allowing the baby to grow. That is the only inference. If we assume that baby was feeling very well. Okay. Right.
It's a very common question, that especially in low birth weight babies, the baby not gaining weight. What possibility should come into him?
The not gaining weight firstly means see the intake is less,
Yeah.
or there is
First, definitely will be inadequacy of weight, or intolerance, or not adequately being fed. Let's say something very basic. Okay.
if the food is okay, when we think about the losses which can be due to infection and sepsis, or could be metabolic causes. Because if
Otherwise, baby looks stronger, then we call it subtle infection. It might be UTI going on. Subtle infection, that is one. Other,
so then we can think about inborn error of metabolism.
strictly inborn errors. Otherwise, normally any child. Baby has to spend a lot of energy in maintaining its temperature only, then that also becomes its cause.
So hypothermia,
Very important.
then hypoglycemia or
Hypoglycemia होगा तो वो tolerance नहीं करेगी.
Hypoglycemia is the result of not getting well, not as a cause of not getting well. What is four milk syndrome? That is something you have already, you can go with back somebody else. Yes, you are. What is four milk syndrome? Which can be a cause of not gaining weight. Four milk syndrome. No. जो आंसर कर चुके हैं उनका हो गया. I think people will not answer anything like this side. What is four milk syndrome? UCMS.
So the initial milk has more water and less nutrients, and the milk which comes after 5-10 minutes, which is called the high milk, that is rich in nutrients. So if the mother is feeding for a very short period of time, if she feeds for 5-10 minutes, then removes the child, puts it on the other breast, or in general only the duration of feeding is very less. So the child is taking only the 4 milk, which is less in nutrients. So
Which nutrient?
fats and
Which nutrient?
fats.
All the nutrients are less in four milk. Protein, fat, sugar. So it is four milk has more of protein and lactose, and higher milk has more of fat and lactose. So if you are taking only lactose or mainly four milk, so your calories are lesser and your lactose is more. So that is why these babies, they are feeding very often, but they are very crying, and the perineal rash will have what she said, that it could be all rashes there. Because you are taking a lot of lactose and body cannot tolerate that such of lactose. That is why you may get something like a secondary lactose intolerance because of four milk. But the crux is your mother is feeding very often. She is saying, I am feeding every half an hour. You cannot feed every half an hour. If you are feeding every half an hour, that means you are feeding only for a very short period of time. 5 minutes, and then she is switching from one breast to another breast. So that is also should be kept in mind once we are thinking about causes which is causing distress and not getting it.
Anemia is very important. Just add on to that, please. Anemia, child is not having adequate hemoglobin, that also becomes a cause for not giving proper time. Okay.
So I want to summarize a case that is a 1 month, 8-day-old child, term may be appropriate for gestation weight, a birth weight of 3 kg, poor para 3, abortion one, death one and live one mother, born by a non-consanguineous marriage, with presenting complaints of fever for 3 days, fast bleeding for 1 day and seizure, with failure to gain weight. My probable diagnosis is subsistence tuberculosis.
Subsistence meningitis with failure to thrive. Right. So in your history is complete. So history from exam point of view. From clinical patient care wise, this is okay. From exam point of view, history has different heads. And as an examiner, we are given that head category. Right? Whether examinee has deliberated on these heads. So tell me those heads which have not been covered there. Okay. Yes, we are asking question. Yes. Anything which she has not covered. Yes. Family history. So but you can mention that in dietary history. Breastfeeding history, you can mention dietary history. What else not mentioned? Socioeconomic status. What else? Immunization history. You written it there, but you not mentioned. So what we are saying is that from exam point of view, after history of present illness, eligibility call, just remember that these points have to be ticked. It is immunized for age, she belongs to a whatever status, social status. You have to do any scale you know which is
Upper
important.
middle social economic status.
What is that scale?
Modified.
No, do not mention that. So, okay. Even if you return, so it's for everybody's consumption. And all those points have to be taken. Immunization history. Do you expect a developmental milestone, developmental history for 18 years of age? Any milestone which must have been achieved at 18 years of life, which you want to have a look at? Any basic things. So maybe you are sucking on the breast. And so that's an examination. But in history, responding to sound, looking for breast. So you can always say that baby is developmentally normal. If somebody asks, what do you look for? Then you can always say baby was looking for the nipple, baby was sucking, baby was responding to sound, baby was looking at the mother. Baby may not have visual fixation, but baby still recognizes mother figure or human figure right at birth. Right? So this is developmental history. So this is just to get you more marks, because we have given that in the history these points are not picked, then you can't give marks. Correct? Anything else for the history anybody want to ask?
I think to start the history from the antenatal period of the.
So I think what she did, she presented the chief complaints and a little bit about the history of present illness. Now to get the information in a newborn, you start from the antenatal period from that time. Antenatal period, natal period, what happened that, and then you come back to the other histories. So that's it.
Cerebral palsy case also, we can do the same.
Cerebral palsy case, you have to discover the whole history presently and then you can go back. It all depends on what is the age of the child.
If you see the very birth of this case, it was 3 kg baby, behaved pretty well as far as bleeding start, everything was concerned. So too much of details about antenatal, this natal is not required. Apparently baby was okay. This is something later on which he acquired. Don't waste time, because time is very important in exam. Every examiner has to 7, 8, 9 candidates are there, and wasting too much of time on one aspect which is not leading. Had it been something developmental delay or something, then obviously it was very important. That is not the case in history. Other history was important.
Negative histories.
Yeah, please. Very relevant negative history. Yeah.
Somewhere
What
subsegment feeding diet versus see negative history should be there because there are a lot of congenital heart diseases. there should be some paragraph on negative histories. I guess.
So in this patient, where the pathology is primarily looks like from history, infective, what is the negative histories?
Negative histories may there should be history of any runny nose or any ear discharge, history of suppressed subcycle, bleeding diaphoresis.
See, I think if it's infective, then my first negative history will be discharge from umbilicus. Tonsillitis will be first negative history. Pustules on the body,
Excessive crying during micturition.
that also can be there. So, but first and foremost, tonsillitis and multiple pustules coming at multiple points. Then will be ear discharge. Then will be the running nose. Yes, all babies are sneezing, all babies are snorting because of nasal blockage. Right? Rashes on the body can be a negative history. So that is just to complete the list. Nothing more important will be tonsillitis, pustules, and others. And any other point in history? Just finishing the history. Anybody want to ask anything? Okay, let's go to the.
On examination, child is lying in mother's
This is examination at what point of time?
on Neoflex 1 month and 6 days, 8 weeks, today.
So whenever you start examination, because the patient is, you must have examined the patient yesterday in the box. You may have examined the patient just now. You must have, this is the examination maybe at this age, not age.
Today, at the age of 1 month 8 days, child is lying in the mother's lap in disturbing surroundings in vector neurobehavioral stage 4, moving all four limbs actively with a cannula at the left dorsum of hand. The posture of the upper limbs is flexed at elbow and lower limbs are partially flexion at hip, knee and ankle. The abdomen is distended and the child is pale. There are multiple erythematous lesions present on the right chest and abdomen with scarring. The child appears malnourished due to loose skin folds on buttocks and thigh. Vitals temperature measured in the left axillary area was 100.9 degree Fahrenheit.
Just a minute. So now you have to, systematic examination has to be done, right? So once you examine, first you tell the general appearance. Examination में बता दिया. Then you come to the anthropometry, vitals, and then you tell the others. So suppose the vitals are not good. Then I am not expecting you to examine very thoroughly. Then I am expecting you to examine most important part. If vitals are stable, then I will expect you to examine thoroughly. So general appearance, anthropometry.
At 1 month 8 days, the child has a weight of 2.23 kg against expected of 4.2 kg, which is less than minus third standard deviation. Has a length of 48 centimeters against expected of 53.7, which lies between -2 to -3 standard deviation. A weight for length was 2.23 kg against expected of 3 kg, which lies below minus third standard deviation. Head circumference is 32.3 centimeters against expected of 36.5, which is also below the minus third standard deviation. The chest.
So how will you interpret the three things?
So there is failure to thigh. As the weight is less than minus 2 standard deviation, there is microcephaly.
Is there any disproportionate?
Yes, sir. Just
not the weight. There are three things you mentioned: weight, and circumference, and length.
Right.
Are all of them are equally affected?
So weight is affected the most, followed by length, and the weight and head circumference are affected the most, followed by length.
Length and head circumference is least.
Yes.
What does it tell you?
Head circumference also less than minus 2 standard.
So length is affected less.
Weight and head
Circumference
circumference
are
are
affected
affected
more,
more,
and length is affected less. What does it tell you?
So that the disease pathology process is more acutely affecting the child than chronically. Because chronic disease is affected length more. But
So it is acute or chronic. So you are saying length is also affected.
affected.
But weight is affected more. So from this information we get it is something pathology is acute or chronic. But head circumference is also affected, which we don't expect in 1 month to go down. What does that tell you?
When I measure the chest circumference, I can see that the head
Newborn chest circumference is not very big. Right? In our hospital we don't measure chest circumference. Right? But in any case, if head circumference, what does it tell you?
So when head and chest have a difference of 4 to 3, then we suspect IUG. That is why I measured it here.
After IUG, go with your 2.23 AC minus 3 cement dilation.
That will actually imply more EUGR than IUGR because the weight at birth was 3.
Let's make it simple for you. If the head circumference is affected, and I don't expect the head circumference to be affected in 1 month of age. It is all apparently all right in 18 days. That means something is going on at the age. So now 2 pointers, chronic malnutrition and low head circumference tells me that something has been abnormal for a very long period of time, and we don't know what it is. But yes, whatever true weight loss is affected, that is okay. But we have to think not only for these 30 days.
Yes.
We have to think much beyond 30 days. This is anthropometry vitals.
So mother's BMI also measured because mother's BMI was also measured because it's a child suffering failure child. So the mother's BMI was 22.5, so she is not.
Whether baby's weight is 3 kg. The BMI does not matter.
The vitals, the temperature in the axillary area was 100.9 degree Fahrenheit. Pulse rate was 144 per minute.
100.9.
Yes, sir.
Still the baby is
Check has stable rate.
despite being in hospital for 20 days,
Yes,
I still has fever. How do you measure the axillary temperature? Somebody who has not answered. Yes, yes, sir. How do you measure the axillary temperature? So use the pen in your hand and measure it on yourself. Steps. Yeah.
So we use the digital thermometer.
What's the treatment available now?
Yes, sir. We keep it in the axilla and we keep it till it beeps.
How will you keep it?
What precaution you take before putting it in?
We keep it like this. Parallel
Before that.
to the chest
Before
wall.
you put-
Sterilize it with the 70% isopropyl alcohol.
And
When we let it dry, because let it dry, otherwise it can lead to hypothermia and
only
newborn.
dry the thermometer. Don't dry anything else.
I try the axilla.
Dry the axilla. Very wet.
Then after that, we will keep it parallel to the chest wall in the newborn
Just
because
show it. How will you do it? It has to be vertically put. And
because if we put it horizontally, then it can overshoot the axilla.
right.
And then let it stay there till it beeps. And then we will water.
So wash your hands, number 1, wash the thermometer, number 2, dry the thermometer, number 3, dry the axilla, number 4, keep the thermometer vertically in the topmost part of the body. Then if you keep it this, it's not enough. So what we say that raise the arm, put the thermometer, let the arm fall onto the thermometer. If you allow that, then always the thermometer will reach the topmost part of the body. And then wait for the beat to come. Okay. Yes.
Respiratory rate is 52 per minute. No sign.
52 beats per minute.
Then this respiratory rate.
How long will come in to get the respiratory rate?
So 1 minute.
1 minute.
There was no sign
And
of
what was the type of respiration?
So no signs of raised respiratory effort. The CFT was less than 3 seconds. The RBS was 89.
You did some scoring to quantify the respiratory distress?
Yes, sir. It was down scoring. There was no respiration.
0.
The saturation 96% under room air. The hydration was normal.
Whenever you tell saturation, you have to tell me something more also.
Under room air.
Saturation 96%.
Under room air.
And which part of the body?
But in the right foot.
It was a right. But you also always have to tell me that. So which part of the body you have?
Hydration was normal, the oral mucosa and tongue were moist, and skin pinch was bad with
Now you are saying that clinically there is no dehydration. There is very distant 2.2. So initially we were thinking about dehydration fever, things like that, but clinically she feels there is no dehydration.
On general examination, there is no cyanosis, no pallor, no jaundice, no signs of no plethora. on head to toe examination. The hair is normal in texture, color and distribution. The head appears small in size, symmetrical in shape. The anterior fontanelle is at level and it's 0.5 into 0.5 centimeters. The posterior fontanelle is closed. There is overriding of sutures present. On the face is symmetrical. All facial expressions are symmetrical, and on the cheeks the buccal fat is preserved.
We measured the head circumference.
Yes.
You did? Let me do something.
It was 32.3.
So, what's the difference in head circumference and occipitofrontal circumference? What is OFC? What is head circumference?
We measure the occipital circumference.
What is the difference between OFC and head circumference? You are interchanging these words. You said head circumference, then you said OFC. Is it same, different?
We measure the occipital circumference.
But is it same, synonymous words? They are different words. They have different meaning or they are same words?
Anybody?
So we take the OFC 3 times and the highest measurement we.
That is okay. Are they same, synonymous words, head circumference, OFC, or they have different meanings?
So in hydrocephalus, we use the OFC.
Others we use head circumference. So, any circumference of the head can be head circumference. You can measure it here, you can measure it little down. Everything is head circumference. Head circumference is an English word. What we are saying is that you measure occipitofrontal circumference, which is telling me is the maximum head circumference. So this is the maximum. That is why she is saying measure it 3 times and take. So basically we are trying to say, we are trying to use the occipital protuberance. We are taking the orbital ridges, and that is where we are, and a non-stretchable tape. So that we make it sure that we take the maximum. Head circumference is any head circumference. Maximum head circumference is occipital circumference. But you said there is overriding of bones.
Overriding sutures.
Which sutures?
So, coronal lambdoid bones.
Coronal lambdoid bones. Not the mitopic. Not the.
No, mitopic nahi.
Mitopic nahi. And mitopic fuse there as well.
Mitopic fuse.
What does it tell you? Why there is overriding?
So, the antenatal pathology affecting the brain growth will lead to.
So,
Brain growth is not a thing.
So overriding of bones tells me that the brain is not growing. It may start growing if you take care of the other thing, but if you are saying it's not being adequate and is overriding of bones, that's not a risk.
Continuous head to examination, eyes. There is no conjunctival scar, no neovascularization, no hemorrhage in the conjunctiva. In the ears, slight watery discharges.
What is red eye reflex? Have you checked red eye reflex?
Sir, I've put that in favor.
Separately. But red eye reflex is not in cranial nerve.
Nobody could do it. There's no red eye reflex.
How do you examine red eye?
So I use the ophthalmologist.
Which ophthalmoscopy? Direct or
Direct.
direct? How do you do it?
So first we dilate the eye of the child.
You dilate the eyes, you put eye drops.
No, sir. For red reflex we don't need to put eye drops. For
You
dilate.
said you did it.
So I did both. I checked the fundus also and I did.
For red eye reflex.
We don't need to dilate for red eye reflex. So for red eye reflex we can we just need to focus the light on the pupil. And
What is the distance of the examiner from the baby in red eye reflex?
30 seconds, 40 to 30 seconds.
Anybody? How you see red reflex, very important.
For
Anyone
direct
has to be seen for this.
and for
So
red
now
eye
routine direct ophthalmoscopy, you go
Be
close to
much
that.
closer.
You have to get your fundus looking very close. But in red eye reflex, you are away. You are at 30 centimeters. Why you are at 30 centimeters?
So because we just need to see the reflection of the fundus. Now we don't focus on the capillaries and the
You are not looking at the retina. You are just looking at the red eye reflex through the cornea, pupil and the retina. You see what you see? Red is retina. Nothing else is red. And you are seeing it through the eye, through the eye. Right? Cornea is transparent, then lens, and then the retina. So you are seeing through them. So if it is red eye reflex is present, and you are comparing the two sides. That's the most important part. Laparoscopy is examining one eye first, examining the other eye first. Here you are examining both eyes at the same time. Right? You are looking into this and you see both eyes. Right? And what does it tell you?
So that there is no opacity in the pathway of the light. So the cornea, the lens, the vitreous humor, there is no cataract, there is no.
So one is that you are telling me that it tells me that his pathways is bright. What else? It tells me 5 things. Doesn't tell me only the brightness. What else?
If it's bilaterally equal.
It will equal. It is possible that both are bright, but if something is little lesser brighter, it also doesn't have the pathology. What else? Somebody from there, yes. You have done red eye reflex, the last one. You have done? Which place you are from?
RN.
So you don't do red eye reflex? What is RPSK? So in RPSK it is mandatory. All babies who are discharged from the hospital, red eye reflex should be done and documented. Both words are equally important. Right? So if you are not doing it, I'm sure I'm sure it must have been said in these many words, it has to be done. Right? So, anybody, how many of you are not doing red eye reflex and documenting in your discharge slips? Not doing. Everybody is doing. अभी तो उसने बोला वो नहीं कर रही है, नहीं कर, काफी लोग नहीं कर, तो करना है, क्यों करना है? Why?
Something will get detected later on, not be a good thing.
So why we want to detect cataract or leukocoria right at birth? Why? Or does it matter?
Affect the visual fixation, visual development of the child.
कोई बात नहीं, 3 महीने के बाद हो जाएगा, कैटरेक्ट 3 महीने के बाद ऑपरेट कर देंगे, 4 महीने में कर देंगे, क्या?
Enlypia of the normal eye.
एम्बलोपिया हो जाएगा, समथिंग वेरी स्पेसिफिक आंसर। पर हीलिंग है, 9 महीने तक भी आप प्लान कर दो, 3 महीने पे इंजीनियरिंग लगा दो, कोई नहीं चल जाएगा। विजन में ऐसा क्या खास है? यू वांट टू डायग्नोज राइट एट बर्थ। Retinoblastoma is the rarest of rare. Yes, possible, yes. If you don't give light to the retina, macula will not develop. So even if you do cataract, even if you take care of leukocoria, even if you take care of vitreous age, after 3 months of age, that child will never see. You can take care of the retina, you can take care of the medium, but you cannot develop the macula. So early detection of corneal opacity, cataract before 3 months of age. So that is why I want to diagnose right at birth, so that we are able to start treatment and give a lens or give at least not lens, at least a transparent media. So that light starts going into the eyes and the macula develops. And it can be medical legal problem also. So if you miss a cataract, if you miss something which is treatable, the child becomes blind. Because after 3 months, 4 months, even if you diagnose, you treat, patient will not be able to see properly. And it is mandated by RPS. That is why it is important that all of you can document.
You said amblyopia, in that case LPI is covered just to stimulate the stimulation. That's very important to give light to the
And unequal size of retinals. One is brightness, both sides. One may be white, both the ways may be white. One will be lesser bright than other. Size will be lesser. You may have smaller pupil on one side, anisocoria. So all those things can be easily diagnosed by red eye reflex. What is the best time to do red eye reflex? Is it easy to open eyes of the baby? What is the best time when they open eyes on their own? Discharge.
Yes.
Even discharge. Discharge से बच्चा तो 1.8 days का तो हो गया, running from discharge होगा. So at birth they are awake. They just come out and they are looking where I come. वहाँ पे आ गया हूँ मैं.
So many times you must have seen babies quite awake for a few minutes after birth, looking around everything. That's the best time to see all these things.
So if the baby is not opening eyes, what do you do to make the baby open eyes?
Dark room, because light of course.
Dark room में तो खोल भी लेगा तो आपको दिखेगा. What is a mechanism, maneuver which you do in newborns to make them open their eyes? Yes, आप read. Yes, आपके पीछे है. What is the question? क्या question पूछा है मैंने? आपसे.
Make the one eye open the eye.
So what's the answer? Ravi was Yes, labyrinthine reflex. What is that?
Tap the.
No, that is glabellar tap. It's a glabellar tap from the UCMS. Have you seen baby dolls? So just hold the baby like this and they open their eyes. So that's the best way to make them open their eyes. Many times parents will tell you vestibular reflex. Vestibular reflex can also be done. So this is even simpler. Yeah, that mechanism is true. It's very simple. Many times parents will tell them, but the बाकी नहीं खोल रहा था. क्या है? नहीं.
Or ears, there is slight watery discharge coming from the left ear. In the mouth.
Examine the ear. Use the otoscopy. How many of you have otoscope in your NICUs? Your baby is crying, baby has fever, baby has some kind. Do you do otoscopy? If you are doing, start doing it. Number one. Number two. What is difference in otoscopy of a newborn? Is a pediatric patient? How do you examine this?
It's at the same level as parallel needs and not forward.
So with the pediatric patient, you just put it up and laterally. And this newborn, you have to put it down. So if you are not doing otoscopy, then how will you examine baby's ear? This baby has ear discharge. If in this baby also you don't do otoscopy, so which baby you will do? Maybe he has got some, I'm sure he has got some perforation ideas from where the pus has come. Some discharge is still there.
Anything you are not doing routinely will never come into your mind once it is little anxious. And during exam and pretty sure everybody is little anxious. Make it a habit from today onwards. These things. That reflex and otoscopy, two messages.
Once you get your bronchoscope, it has the same blade but it's a separate attachment. You can have the otoscope as well.
So oral cavity in the mouth, there is a cleft palate in the submucosal area at the junction of the soft and hard palate, and the uvula is absent. There is no ulcer or gum. The tongue
What
has
is the relation of cleft palate and diabetes?
yes, sir, cleft palate predisposes to ear infection. The nose. So it was a pinched nose, which I had a pinched nose, might get little peaking. And the nasal cavity had greenish discharges.
Greenish discharge.
Dry, sort of crusted. The neck, there is no mass or lymph node and neck has
In
no.
cleft palate, you said this ear problem is why? What do you think is caused?
So the seeds and secretions can
Why they go like this?
because the normal palate and the pharynx cannot close properly to
It's
be
basically direction of eustachian tube, I would say. It's not that, angulation is that not that, it's roughly 10 degrees when the baby is born. As the mid phase swells, it gradually becomes more angulated to the horizontal plane. In adults, it is roughly 45 degrees. That's one mechanism, or one reason for that.
The neck has no mass on its own and the neck has normal mobility. The skin, there is loose skin folds over the buttocks and thigh, no follicular hyperkeratosis, no scaling, no cracks, no eczematous eruption, no hyperpigmented freckle. There is on the right chest and abdomen, the skin of the right chest and abdomen, there are 7.5 centimeters or 0.5 centimeters erythematous scarring, healing, circular lesions present.
Eye size of both is normal. It's equal. Left eye is the highest. Left eye is more in the right. It will do the more. On the right side, whatever you want, my idea. चिंता नहीं करें, चेकअप करने का तरीका ऐसे बच्चों को नुकसान। I think post-history examination or that's how do you examine the
sharp margin for consistency and stability. And when we examine the just
Yes, please, continue.
just
So obviously, this baby is alert, active, not dehydrated, looking around. He's not acutely sick, right? But still his weight is less. And he has got some dysmorphic features, left palate, no, some skin. He has got impediment, right? And some punched out skin lesions as well. And also, yes, right.
so there's a it hasn't been 6 even this type of product.
definitely, this is these skin lesions which are punched out still have some pus, some have them are scarred, some are still draining pus.
बंदा करता है, they could have been more closer to differentials and all. Do you agree with this?
Yes.
Because head growth, this, that thing was not elicited much in university, but वो सारा ठीक हो गया after examination of the child. So let's see एक बार देखेंगे इसको what it comes out क्या है. Because we have not been able to pinpoint what exactly is there in the child. Child is somehow maintaining twice blood transfusion has been given in spite of that which is falling. That's another point because it was not part of history and examination.
More productive pathology to be identified. No infection came in cultures, everything was.
Yeah, here in anthropopus in here result is
Blood cultures are all negative.
blood culture is negative. CSF is absolutely normal. The only finding which could tell us about season was that concurrently hypocalcemia came. And child responded also for 48 hours IV calcium was given, no seizure spread. 90%. We just kept this way because multiple links were opening for discussions. Thank you, Dr. Pankaj, for your ideas. And the very idea, because you can't cover the whole neonatology in one lecture, the very idea of this was just open your all neurons in which way you have to do it. Quickly, that too quickly. Sir. Thank you so much.
Well, I sincerely thank both of them in good hands. I think it was quite useful for all of you. Okay. I sincerely thank Dr. Pankaj for having come from the physician unit. Yes, reach the Gangara hospital again. So, sir.
Thank you so much, sir.